Good afternoon, and thank you for joining us for HPIO's webinar on Ohio Medicaid Basics 2017. I'm Nick Weislogal, Vice President for Strategic Communications at HPIO. Our Medicaid Basics brief, as well as a two-page executive summary, are available on our website at hpio.net. The slides from today's webinar and a recording also will be posted on the Medicaid Basics page. Because of the large number of callers we're expecting today, all phones have been muted. Please feel free to type questions in the question box at any time, and at the end of the presentation, we'll try to get to as many as we can. If you don't see the question box, your control panel may be minimized. To bring it back, click the orange arrow in the corner of your screen. We're going to start today with HPIO staff member Zach Reed giving an introduction to Medicaid Basics, and later we'll hear from a panel of presenters giving their perspectives on Medicaid in Ohio. Our guest speakers include Stephanie Gilligan from the Ohio Hospital Association, Steve Wagner from UCAN, Ohio, and Angela Weaver from the Ohio Association of Health Plans. And now here's Zach.
Thank you, Nick. So during this presentation, we'll walk through the Ohio Medicaid Basics 2017 publication. The publication gives an overview of Ohio's Medicaid program, including current eligibility standards and up-to-date enrollment figures, covered Medicaid services, total program spending, and finally the federal and state arrangements that govern administration and financing for the program. We'll also talk about the Medicaid program in the broader context of the health insurance market for low-income Ohioans and highlight some things to watch for throughout the remainder of the state budget process and as the federal government continues to consider healthcare reforms, literally as we speak. Our guest speakers will share their perspective on the Medicaid program and some thoughts about current trends in the program, including changes to the proposed budget bill. But before we get started, I'll quickly share some information about the Health Policy Institute of Ohio. The Health Policy Institute of Ohio was founded in 2003 by a group of core funders that continues to fund the organization today. On this slide, you see those funders and others that provide core funding to the organization. HPIO's mission is to provide the independent and nonpartisan analysis needed to create evidence-informed health policy. One way that we do that is through written and online publications like Ohio Medicaid Basics. HPIO publishes Medicaid Basics every 2 years to coincide with the state budget process. The 2017 edition provides an overview of the program, discusses the role of Medicaid in the health insurance market for low-income Ohioans, and highlights things to watch through the budget process. Ohio's Medicaid program is often confused with the federally administered Medicare program. You may be familiar with this graphic. It's been featured in previous versions of the publication and highlights some of the key differences between the programs. Three of the primary differences are that Medicaid is for most low-income Ohioans, while Medicare pays for healthcare coverage for nearly all Ohio seniors. Medicaid is funded through federal and state dollars with local contributions, whereas Medicare is funded through federal funding. Finally, Medicaid covers long-term services and supports provided in a nursing home setting, but Medicare and most commercial insurance does not. Now we'll talk a little bit about Medicaid enrollment numbers and briefly review the current eligibility standards. So as of 2016, nearly 73 million people were enrolled in Medicaid across the country. That number has increased significantly since 2014 when coverage provisions from the ACA went into effect, including the expansion of Medicaid to adults with income up to 133% of the federal poverty level, or FPL. In Ohio, during state fiscal year 2016, an average of more than 3 million people were enrolled in the Medicaid program each month. That's more than 26% of Ohio's total population, or 1 in 4 Ohioans. Typically, Medicaid enrollment increases during periods of economic downturn and in response to federal or state eligibility changes. This slide shows Ohio's average annual enrollment since 2003. Enrollment increased significantly during the Great Recession and when enrollment was expanded to newly eligible adults. In general, children, parents, pregnant women, adults with children, seniors, and people living with disabilities are eligible for Medicaid if they have low incomes and meet other eligibility criteria. It is important to note that different categories of Medicaid have different sets of eligibility criteria. For the sake of this analysis, in Medicaid Basics 2017, we condensed the Medicaid eligibility categories into 4 groups: covered families and children, or CFC, age blind and disabled, or ABD, Group 8, or the newly eligible adults, and then other Medicaid categories. Before 2014, when coverage provisions from the ACA went into effect, states were allowed to design and use their own income counting methodologies to determine eligibility. To standardize income counting across states, the ACA introduced a new methodology called MAGI, or Modified Adjusted Gross Income. The ACA also mandated that states adopt the methodology and start using it in 2014. Today, people applying for Medicaid in the CFC, Group 8, and some of the categories wrapped into the other Medicaid group are subject to the MAGI income counting rules, while people applying in the ABD category are subject to income counting that also applies to the Supplemental Security Income Program, more commonly known as SSI. The calculation for MAGI combines all taxable and some types of non-taxable income for a household, and then applies a 5% income disregard before determining if a household meets the income eligibility standard. After applying the 5% income disregard, adults are eligible for coverage up to 133% of poverty. Now, just to give you some context, that's about $16,000 per year for a single person, or about $32,500 for a family of 4. Pregnant women are eligible for coverage with income up to 200% of FPL. Also, if a pregnant woman is found to be eligible at any time during her pregnancy, she remains eligible for at least 60 days after the birth of the child, regardless of changes that may affect eligibility. In addition, children born to mothers covered by Medicaid are eligible for Medicaid coverage until their first birthday, regardless of changes, again, that would affect eligibility. Otherwise, children are eligible for Medicaid with household income up to 206% FPL. Notably, children with other sources of health insurance coverage are only eligible with incomes up to 156% of FPL. As mentioned a couple of slides back, people applying for Medicaid in the ABD category are subject to income counting and eligibility standards for the SSI program. The eligibility determination process for SSI looks at income, resources, age or disabling conditions, and other criteria such as citizenship and work history. Some people are eligible for both Medicare and Medicaid. People that are dually eligible may receive full Medicaid benefits through the ABD program or Medicaid buy-in for workers with disabilities. Or they can get financial assistance to cover the costs associated with Medicare through the Medicare Premium Assistance Program. Now we'll break to launch a poll question. And let me just pull that up here. Okay, so the poll question is, which of the Medicaid enrollment groups has the largest number of enrollees? So please select the answer, and we'll let you know what it is in just a few minutes here. So just as a reminder, covered families and children includes children, parents, and pregnant women. Age blind and disabled is for people who are over the age of 65, blind or disabled. Group 8 is newly eligible adults. And then Medicaid is other programs such as the breast and cervical cancer program or alien and emergency medical assistance. Okay, so we'll go ahead and close that poll. And it looks like 81% of you selected the covered families and children group, and that is correct. And later in the presentation, we'll look at just how much of the total Medicaid enrollment population is made up of the covered families and children group. Okay, so now we'll talk about the Medicaid covered services and program administration and financing for Medicaid. So Ohio Medicaid covers a comprehensive set of services, including all of the federally mandated services and some allowable optional services, including dental and vision care and prescription drugs. Medicaid is administered and financed through a federal-state partnership, and CMS is at the federal level, the agency responsible for administering the program. That's the Centers for Medicare and Medicaid Services. At the state level, the Ohio Department of Medicaid is the single state agency with responsibility for administering the program. And then JMOC, or the Joint Medicaid Oversight Committee, was created in 2014 to provide legislative oversight for the program. Several documents outline the administrative agreements between the federal government and states. The Medicaid State Plan outlines eligibility standards, covered services, and administrative procedures for regular program operations. Waivers are in place to do things like test new programs or delivery systems, provide services to populations with special needs, or provide services in limited areas of the state. Waivers and state plan amendments must be approved by the Federal Centers for Medicare and Medicaid Services, and a full set of active and expired waivers is available at Medicaid's website, medicaid.gov. Medicaid is financed through a federal-state reimbursement arrangement called Federal Medical Assistance Percentage, or FMAP. The federal government reimburses states a specific percentage of healthcare costs incurred based on the category of Medicaid in which a person is enrolled. Regular FMAP is calculated using a formula that provides a higher FMAP to states with lower per capita incomes. In Ohio, most Medicaid recipients are eligible for a 62.3% FMAP. That means that the federal government would reimburse $62.30 out of every $100 incurred for healthcare costs. However, the federal government offers enhanced FMAPs for adults enrolled in Group 8 and children enrolled in CHIP. For adults enrolled in, or for people enrolled in those categories, Medicaid will, or the federal government will reimburse about 95 or 96% of total healthcare costs incurred. In Ohio, during state fiscal year 2016, the federal government reimbursed 69% of the total $25.3 billion spent on the Medicaid program in Ohio. That was approximately $17.6 billion last year. Total program spending for Medicaid has increased by over $7 billion in Ohio since state fiscal year 2012. However, enhanced reimbursements from the federal government have limited the impact of spending growth on Ohio's General Revenue Fund. Spending from the General Revenue Fund for the program has increased by less than $1 billion during the same time period. Next, Ohio Medicaid Basics looked at some reasons why people with low incomes in Ohio enroll in Medicaid. Most of these reasons are related to lack of access to other coverage options or simply having low income and being unable to afford other health insurance coverage options. The first issue the brief examined is employer-sponsored coverage offer rates for people with low incomes in Ohio. People with low incomes are less likely to be offered or to be covered by employer-sponsored insurance. In Ohio in 2014, nearly 90% of workers with incomes above 400% FPL had employer-sponsored coverage, compared to less than 30% of people with incomes below 138% of FPL. Next, the brief looked at unemployment and other changes in life circumstances that change access to coverage or reduce incomes. Other changes might include temporarily caregiving for friends or relatives, changing jobs or careers, illness or injury, or attending higher education or job training. Next, purchasing coverage on the individual market is simply unaffordable for many people with low incomes. As you may know, people who are eligible for Medicaid are not eligible for subsidies to purchase insurance on the ACA marketplace. The average unsubsidized premium for an individual on Ohio's ACA exchange in 2016 was $405. That would be nearly 1/3 of a person's monthly income, earning 133% of federal poverty. Finally, many commercial plans purchased through employers in the individual marketplace come with high deductibles. In fact, in 2016, the average family deductible for a high deductible health plan was $4,364. This graphic illustrates the disproportionate impact of high deductibles on families with low incomes. A low-income family with a high deductible health plan and high medical utilization has less money to pay for other necessities, such as food or utilities, after paying the deductible. Research shows that the disproportionate impact on high deductibles on people with low incomes results in delayed and foregone care. Finally, the brief looked at Medicaid as an important source of coverage for people living with disabilities and those in need of long-term services and supports in a nursing home setting. People determined eligible for Social Security Disability Insurance, or SSDI, may enroll in Medicare after a 24-month waiting period. Depending on income and other eligibility criteria, those people may be eligible for Medicaid during that waiting period. With some exceptions, Medicare and most private insurance does not cover long-term services and supports provided in a nursing home setting. Medicaid, in fact, is Ohio's largest payer of nursing home services and paid for over 70% of nursing home services in 2016. People on Medicaid access healthcare services through one of two delivery systems: fee-for-service, or traditional Medicaid, and managed care. Ohio has worked to enroll a majority of participants into managed care plans, and the executive budget proposal included the remaining people on the fee-for-service program into managed care plans. The managed care delivery system uses Medicaid dollars to pay privately operated health insurance providers to give Medicaid enrollees access to services. Now we're moving into the things to watch for segment of the presentation. The Ohio Department of Medicaid administers a pay-for-performance program to track the performance of managed care plans and reward performance that it exceeds a benchmark set based on the performance of managed care plans nationwide. Medicaid managed care plans nationwide. Plan performance is measured on 7 metrics related to the Department's of Medicaid's quality strategy. In state fiscal year 2016, Ohio managed care plans were awarded $48.5 million out of a total possible award of $142.1 million. The publication also highlights other initiatives to pay for value, including Ohio's federal state innovation model grant and the comprehensive primary care and episode-based payment initiatives. So during our earlier poll, you said that you thought the CFC group was the largest in terms of Medicaid enrollment, and you were correct. So this graphic shows that how much of total Medicaid enrollment each group makes up. And then the second bar chart shows in terms of expenditures how much each group uses. Across the country and in Ohio, the ABD group has the most complicated and expensive conditions to treat. In state fiscal year 2016 in Ohio, ABD enrollees accounted for about 12.3% of total enrollment and about 47.8% of total expenditures. As Ohio's population continues to age, more people will be enrolling in the ABD category, increasing the total cost of the Medicaid program over time. In addition, nationally, the cost of providing healthcare services to people who are elderly and disabled is expected to grow significantly. Spending growth coupled with changing demographics may cause continued growth in total Medicaid program spending. So now, as we prepare to answer some of the questions that you typed in during the presentation, we're going to pull up another poll question. And that poll question is one that's really to help us improve the Medicaid Basics document and think about the content of that document. So the question is, of the sections of the document, which will be most helpful to you throughout the remainder of the state budget process? Eligibility enrollment, where we talked about current enrollment standards and up-to-date enrollment figures. Covered services, where we talked about the healthcare services that will be paid for by Medicaid. Administration, finance, and spending. And then finally, the portion where we talked about some things to watch for in the budget, or how Medicaid fits into the larger health insurance market for low-income Ohioans. Okay, so we got about half of you to vote, and it looks like pretty even distribution across the different sections there. So now we'll take a quick break and see if there are any questions that you've typed in that we can address before we move on to our guest speakers.
Yeah, just had one quick question. Someone wanted to know if people are collecting SSDI and are over the income limit for ABD, are they eligible under the Group 8 expansion?
Based on the amount of the SSDI and any other income that they have, so long as their income was below the eligibility standard, they would be eligible. Okay, we must have covered everything very thoroughly. There weren't many other questions there. So now we'll move on to our guest speakers. And our first guest speaker is Stephanie Gilligan. Stephanie serves as the Director of Advocacy for the Ohio Hospital Association. She joined OHA from the Health Policy Institute of Ohio, where she held the role of Director of Access and Coverage Policy. Prior to working at HPIO, she worked at the Ohio Legislative Services Commission. She started her career as an LSC Fellow and then covered the Health and Human Services issues as a budget analyst, and later coordinated the LSC Fellowship Program. A native of Cincinnati, Ohio, Stephanie earned a bachelor's degree in political science and a master's degree in public administration from The Ohio State University. Take it away, Stephanie.
Thanks, Zach. And thank you for inviting me to be a part of the webinar today. I'll also start my remarks by apologizing that I have a cold and I'm losing my voice, so if I sound a little scratchy, that's why. Well, as Zach said, I am a Director of Advocacy at the Ohio Hospital Association, so just wanted to give a little bit of information about who OHA is before I move on. We represent about 220 hospitals and 13 health systems across the state, and our mission is to work with our members to ensure a healthy Ohio, and we do that through three main functions, which are advocacy, economic sustainability, and patient safety and quality initiatives. And then just a few fun facts that help illustrate the role that OHA plays in our state. In 2015, Ohio hospitals had more than 32 million patient encounters, and we're also major economic drivers. Ohio hospitals directly employ over 250,000 Ohioans and indirectly support another 250,000 jobs, and it all adds up to more than 15 billion paid in direct wages. The landscape for hospitals right now is really challenging. They're confronted with a lot of uncertainty. As we've been on this webinar today, the House passed the American Health Care Act to repeal and replace parts of Obamacare. And that's just one example of the uncertainty facing the entire healthcare sector, really. And even with the state's expansion of coverage through Medicaid, 16% of Ohio hospitals currently operate at or below a 0% operating margin, and nearly a quarter of Ohio hospitals are operating below a 2% margin. So I just share that fact to kind of illustrate the financial realities that hospitals are facing today, as there have been so many healthcare reform efforts that have changed the care delivery system, involved significant reimbursement cuts, and other funding challenges. Here at the state level, we're watching a number of issues in the state budget, and I'll highlight just a couple of those, and I'm also happy to answer any questions. First of all is Medicaid expansion. We were really pleased to see that the executive version of the budget maintained current Medicaid eligibility levels. We understand that we need to have conversations about the fiscal constraints that the state is facing and personal responsibility, but we believe it's important to maintain access to care for the more than 700,000 Ohioans who have gained coverage because of expansion. Among the many positive outcomes that we've seen over the past few years, we know that these individuals have reported better access to mental health services and an improvement in overall health status since enrolling in Medicaid. Ohio hospitals also see firsthand every day the many health challenges that are facing the state, including high infant mortality rates and drug abuse and addiction, and we believe that maintaining access to care is an important part of the solution. So to those ends, we're still reviewing the changes that the House made this week to the budget, but we are concerned that the language requiring controlling board approval for the release of funds jeopardizes the sustainability of the program. One of the most important considerations for hospitals is predictability of funding, and having to get Medicaid funds released every 6 months poses a lot of potential challenges. The next issue I'll mention is price transparency. There were price transparency provisions included in last year's BWC budget. The executive version of the budget bill removed those provisions so that Ohio hospitals, along with other providers in the state, could work with the legislature to reach a legislative solution, and that process continues. Ohio hospitals remain committed to providing Ohioans with an aggressive, comprehensive, and consumer-friendly healthcare price transparency system. So we are right now, there are no provisions in the budget around price transparency, but we continue to work with the legislature to reach a solution that satisfies all parties. Just two more issues I'll briefly touch on before passing the baton. First is the non-contracting language that was included in the budget bill, and we were really pleased to see the House remove that language. We believed it was unnecessary and supported its removal. 100% of hospitals have contracts with Medicaid managed care plans, and 96% of all possible contracts are in place. And we believe the state shouldn't get in the middle of the ability of two private entities to hold good faith negotiations. An important thing to consider as we talk about the way Ohio's managed care system works is that those negotiations between hospitals and managed care plans are really important, and they involve more than just rates. They often include agreements on coverage, prior authorizations, denials and appeals, and value-based programs. So we are really pleased to see the changes that the House made to the budget in that area. And finally, on the issue of telehealth, we were also supportive of the provision that the House added providing coverage of telemedicine services. The language requires telemedicine services to be covered on the same basis and to the same extent that in-person health services are covered. We think that telemedicine is an innovative way to support healthcare delivery reform, and it's actually already being used by many hospitals across the state as a way to improve access to care, care coordination and quality, and also help reduce the rate of growth in healthcare spending. So we think that this was a really positive initiative that the House put in, and we look forward to continuing that conversation in the Senate.
Thank you very much, Steph. Oh.
Sure. No, I was just going to say I can pass the baton to the next panelist or take questions now.
I think we'll wait until we're done with all the guest speakers before we address any additional questions from the audience, but thank you very much for your remarks.
Great.
Okay, and our next guest speaker, advance the slide, will be Angela Weaver. Angela is Director of Regulatory Services and Supports at the Ohio Association of Health Plans. She is responsible for managing the OAHP Government Programs Committee, serves as a liaison with various state agencies and stakeholder groups, and assists with other regulatory and association activities. Angela joined OAHP in 2013 after serving as the legislative liaison for the Ohio Department of Medicaid and Governor's Office of Health Transformation. Angela also served in various positions in the Ohio Senate for almost 5 years. Angela received a Bachelor of Arts in Political Science from Denison University. Angela, please take it away. Oh.
Great, thanks, Zach. And thank you for having me this afternoon on the webinar. We're very excited to participate, and we're also very excited to see some of OAHP's resources footnoted in the Medicaid Basics document that you guys published. Just so folks know a little bit more about OAHP, we represent 16 member plans who provide health insurance coverage to more than 9 million Ohioans. Our member plans include commercial insurers, Medicare Advantage plans, as well as the Medicaid managed care plans that serve the Medicaid beneficiaries here in Ohio. As a statewide trade association for the health insurance industry, our core mission is to promote and advocate for quality health care and access to a variety of affordable health benefits for all Ohioans. And I'll be focusing mostly on our Medicaid priorities in the budget, as well as an overview of managed care in Ohio. As Zach said, almost 86, you hear 86 to 90% of Medicaid beneficiaries receive their coverage through one of the 5 Medicaid managed care plans or one of the 5 MyCare Ohio plans. Today, we cover populations including children and families, the age blind and disabled adults, children with special health care needs, adopted and foster children, individuals enrolled in the breast and cervical cancer program, as well as an option for individuals with developmental disabilities who receive waiver services. Ohio is we've been using managed care since the late 1970s, and over the years, the state has expanded managed care to be a statewide program. And within that expansion to the statewide program in 2013, ODM really transitioned the program into be really focused on eliminating fragmentation, expanding access, and increasing quality outcomes for those on Medicaid. As Zach indicated, the plans are held to different quality measures. They have over 20 quality measures that they're held to, 7 of which are in the Pay for Performance program that was mentioned. And since the implementation of that Pay for Performance program, the plans have greatly increased the quality of care and their scores on those measures as well. And today, Ohio's Medicaid plans score higher than both the national average and the large state group averages on NCQA metrics for the 2016 and 2017 year. Managed care plans are also to assist in bettering their quality scores. They're held to a standard to enter into value-based arrangements with the providers that they contract with, and state statute requires health plans to tie at least 50% of those contracts to value by 2020, and the plans are at about 25% overall to date and are well on their way to hitting that 50th percentile, especially with the state initiatives like CPC and the episode-based payments. And managed care provides the state with greater budget predictability. The plans are paid a monthly fixed capitation rate, which allows the state to better predict what the cost will be into the future. And in a recent report that we published, our actuary found that between the years 2013 and 2015, the managed care plans, if you compare that to if Ohioans were served through the traditional fee-for-service program, managed care plans saved the state between $2.5 to $3.2 billion. So that is one of the advantages of using managed care on top of the quality that it brings to the state. And in the current budget, we're really focused on 2 priority areas, and now 3 given what the House had passed. The first is ensuring that behavioral health redesign and the integration of behavioral health services are implemented according to the set time frame of the July 1st go live of the redesign and the January 1st, 2018 implementation of the behavioral health integration. We are also tracking the managed long-term services and supports and are very much supportive of that move. Today, more than 20 states utilize MLTSS programs throughout the nation, and 9 of our member plans operate and have experience in those states under MLTSS. And also, too, Stephanie touched on expansion, and we are very much in line with them on the impact that that will have for access and coverage to those individuals we currently serve. We, like Stephanie said, a majority of these individuals have behavioral health needs, and they will continue to have those needs and will need that access. And we also are tracking and moving towards population health, and specifically within the last 2 years, we've been focused on Ohio's infant mortality rate and what we can do to impact that and reduce Ohio's infant mortality rate. In the last budget, the plans were funded $26.8 million to partner with local communities in the 9 hotspot communities to implement innovative programs to better connect women and infants with better quality care and care management. And the state or the administration has put forward those dollars again in this next budget to continue those projects. So those are the top 2 alongside of expansion in terms of Medicaid that we are tracking to. And like Stephanie said, I'm happy to answer any questions once we're finished with the panel.
Thank you very much, Angela. And again, we'll hold questions until after our final guest speaker, Steve Wagner. But if you do have questions, please type them into the question box now, and we will queue those up for a quick panel after Steve is done talking. So Steve Wagner is Executive Director of UCAN, Ohio. He joined the organization in January of 2016. Steve has extensive experience in improving health as a public health professional. He worked for the Oregon Health Authority, overseeing the public health regulatory programs, including healthcare facilities, public drinking water, medical marijuana, and radiation protection. At the Ohio Department of Health, he held leadership positions providing oversight of programs that included health preparedness, chronic disease, and infectious disease. Steve is a member of the Ohio Bar and graduated from Capital University Law School. He also has a Bachelor's of Arts in Biochemistry from Case Western Reserve University and an MPH in Epidemiology from the University of Michigan School of Public Health. Thanks very much, Steve.
Hey, thanks so much, Zach. And I guess I got to remember to edit that down. That was a lot of blah, 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 but thank you. So, hey, UCAN Ohio is an organization, Universal Healthcare Action Network, that works to build and support the consumer voice. Our mission is to assure access to quality, affordable health care for everyone. So we do that by supporting consumers. We help them to connect them and their stories to the media and decision makers. We work to inform consumers of policy decisions and the ways they can engage in policy decisions. You know, we're about, use the word consumer, but it's a way of describing that we're about trying to make sure that the regular people who are getting health care, you know, not providers and institutions that have their own representation, but really, you know, just every person has that kind of voice in how the care they get is provided to them. So Medicaid expansion and Medicaid in general has been a great step towards making Ohio healthy. It's assured that many people with low-paying jobs could get health care. Other speakers have talked already about how much this impacts on those who have disabilities, older adults that need continuous care, and children. The two things that I want to really highlight that are in this existing budget, or that's proposed by the House and passed by the House. The first, I don't believe has been touched on, and that's the requirement within the expansion population, oftentimes referred to as Group 8. And that is, so in this work requirement, if you are not employed, there are some exceptions to being employed, but you cannot be enrolled in the Medicaid Group 8 if you do not have employment. The exceptions, some of them are that you're in school, participating in an alcohol or drug addiction treatment program, older than 55, or that you have intensive healthcare needs. I think I'll tell you that there's a lot of ambiguity about what that means, intensive healthcare needs, as well as what really employment means. I think the tricky thing about this is, frankly, we all want people who have the ability to work to be able to have that opportunity and have a job that provides health care for them. But this bill, this amendment really does very little to do that. So if you are out there looking for a job, trying to find employment, not having health care coverage, not having a way to get care if you're ill, if you have a chronic condition like diabetes, that doesn't help you get a job at all. So this really is an amendment that really doesn't do anything to help us have a healthy workforce. The other thing to talk about is that within the what was talked about earlier, the controlling board having to approve the funds that go to Medicaid for the Group 8 population. Part of that is an expectation that ODM, Department of Medicaid, is going to go forward and apply once again for the Healthy Ohio waiver. If you remember, that's the piece that creates a requirement for people on marginal incomes to pay premiums, as well as the creation of a great deal of bureaucracy around health savings accounts and otherwise. Previously, the Center for Medicaid and Medicare Services denied that waiver request. This would require that the administration once again pursue a waiver request related to that. Premiums are problematic in that they do discourage individuals who can't raise those funds. Discourages them from getting health care coverage. We would expect that we could lose 10 to 15% of the Medicaid population simply because of the bureaucracy that would be involved in this, as well as the difficulty in obtaining premiums. So this, again, is going to lead to individuals who are not as healthy, don't have preventive care, and it's going to cost us more in the end because sooner or later those things are going to catch up and they will end up in hospitals, in urgent cares, to a much higher bill than we would want if we really took care of the preventive care needs that everybody has. So I think those are the two things to watch and be careful of. Those are relatively hurtful to consumers, and I think are ill-designed to improve and create a healthier workforce in Ohio. Thanks.
Thank you, Steve. And just as a reminder, if you have any questions about the Medicaid Basics document or for our guest speakers, please do type them into the questions box. And we've had several questions come through, so I'm going to turn it over to Nick so we can get to those.
Yeah, so the first one is more of a clarifying question, I believe, for you, Zach. If a patient has both Medicaid and Medicare, which is primary?
That's an important question. For people who have other sources of insurance coverage, Medicaid is always going to be the payer of last resort on a claim, meaning that they will be the last entity to receive and make payment on a claim.
And the next one is kind of yet another clarifying question, and I'm not sure who this was addressed to. It says, did you say that Medicaid is the largest portion of long-term care spending? I'm not sure if that was part of your...
Yes, so Medicaid covered more than 70% of long-term services and supports provided in a nursing home setting in state fiscal year 2016.
Okay, now the next series of questions I think will probably best be answered by Angela. The first one is, if a patient's managed care plan no longer works with their primary care provider and their preferred hospital, can that patient withdraw from managed care and request fee-for-service Medicaid, or do they have to wait until the next open enrollment month, November, to change plans?
So that's a great question. So I believe that they are able to appeal paid to change to open enrollment if that is a factor, and then ODM, I believe, will determine whether or not they have the ability to change plans mid-year.
Okay, and then the next kind of clarifying question for you again, Angela. What would be the main reasons that there is so much savings with managed care plans versus fee-for-service?
Sure. So you'll hear Director Sears say this quite often. A lot of it is the care coordination of the plan prevents those that could have occurred. She likes to call them accounting for the never events. So, catching somebody's in an early disease state and preventing them to progress further, or helping someone control their diabetes early on through preventative care, as well as just the administrative overhead that the Department of Medicaid has that the managed care plans do not have. I believe our cost savings analysis applied that was about 0.5%. Their admin was 0.5% more than what the managed care plans would be, and then just it is greater managing the services a member gets. The traditional fee-for-service program is just a payer of claims, and there are no reviews for medical necessity, and also plans do upfront fraud, waste, and abuse reviews as well, where that on the fee-for-service side is done on the back end and often done years after a service is provided, and those dollars oftentimes are never recovered by the department when there is instances of fraud, waste, and abuse.
Great, thank you. I guess I will send one more question your way, Angela, and we'll get Stephanie and Steve involved in the conversation soon. I apologize. The next question is, will the funding for the OEI communities be distributed in the same manner that it was distributed last year, or will it be offered to those programs that have already received funding first?
So, the funding that was done in this current biennium, a lot because of the time that it took for the managed care plans to get around to all 9 communities, a lot of that funding will actually go into the next biennium as well. And so some plans are still in year 1 of their funding of 2 years. The organizations that we're funding are still doing work in year 1 and haven't started on their year 2 funding yet. So we actually talked to the Department of Medicaid this morning about moving forward with the thing, and we plan to meet soon after July 1st to discuss how those funding dollars will go out. We will likely do a similar process we did the last time and allow communities and different organizations to submit proposals for programs, as well as giving those that are currently funded the opportunity to show the outcomes and data that they have done with the dollars they've received to date to they can be funded further into the next 2 years.
Great, thank you. And this next question is for Zach. For the breast and cervical cancer program, is there income requirements? And if so, where is this eligibility? Where can you find out about this eligibility information, and how would a person apply for that program?
Yes, there are some specific eligibility requirements for the breast and cervical cancer program, which I cannot remember off the top of my head, and I'd hate to misquote. But the broader question about Medicaid eligibility criteria and where this can be found, those are all listed on Medicaid's website, the Ohio Department of Medicaid's website, which is medicaid.ohio.gov. And this is also a good time to mention that on the same page that you can access Medicaid Basics, we have other resources about the Medicaid program, including a link to the website where you can get more information about Medicaid and apply for the program.
Next question is for Steve. There's a little bit of confusion regarding Group 8 eligibility with regards to employment. The person says that they thought they heard you say that Group 8 is for people that are employed or for specific reasons have no income, and they wanted to know if that's a new requirement and an employment requirement. Is that a change or something in the works? So I guess if you could talk a little bit about what requirements are currently in place for employment to be eligible for Group 8, and maybe what is in the works as well.
Yeah, so what I was speaking about was what's in the House bill that was passed. So the House bill that was passed put enrollment requirements. So for you to be eligible to enroll, you had to be employed. So that's not currently, right now it's a income standard. There's not a requirement to be employed or unemployed to be able to be eligible for Group A right now.
Great, thank you. The next question is there any funding available for the feds or state for helping with EHR or HIE in Ohio? I'll just let anybody that knows anything about that speak up and answer, any of our speakers.
Jason, what do you think they mean by the HIE?
Can you ask for clarity on?
Yeah, let me see if hopefully somebody, I'll move to the next question. The person, Sharon, that gave that question, if you could clarify a little bit more about what you mean, and send another question, and we'll get back to it. So the next question.
Jason, I assume that they're talking about health records and health information exchange, but I'm just not.
Yes. So yeah, I believe so. That's what health information exchange. Yes, you did clarify. So yeah, is there any funding available from feds or state for helping with a health information exchange or electronic health records?
So this is Steve Wagner. I believe all of that assistance has sunset already. I guess I'd rely on somebody else that might be aware, but I believe that's the case.
This is Stephanie. I will say that there are federal requirements and have around electronic health records and interoperability, and there are requirements for providers and both funding and penalties associated with those changes. That's not my area of expertise, so I don't want to get into too much detail, but if someone wants to follow up with me, my email address is on OHA's website, and I'm happy to look into it in more detail.
Okay. We are done with questions from the group, and I'm just going to ask one that I think is probably on a lot of people's minds, and I'll ask each of you to respond in turn as the last question for the webinar. With federal healthcare reform proposals and the American Health Care Act being just passed minutes ago, and then the potential changes to the Medicaid program within the Ohio state budget, there's a lot of uncertainty around Medicaid's future, particularly the future of the Medicaid expansion, which I think you all mentioned in your comments. So how does the uncertainty at the federal and state level impact the stakeholders that you represent? And then how has it impacted your own organization's operations? So we'll start with Stephanie and then move on to Angela and Steve.
Sure. It's a big question, and I'll say that the uncertainty in the landscape right now is a key concern for hospitals in Ohio and really across the country. I have two examples which might be even slightly outdated as of a half an hour ago, but just thinking back to when the ACA was passed in 2010, the CBO estimated that the law would expand coverage to about 30 million individuals and cost about $1 trillion over 10 years. About half of that cost was paid for through new taxes and fees, and the other half through reductions in federal spending. So of the about $500 billion that was paid for by spending reductions, about $155 billion of that was taken from hospital payments, and that includes cuts to Medicare and Medicaid DSH payments, payments associated with delivery system reforms, and various other changes. And so for hospitals, there's a lot of concern about rolling back the gains we've made in coverage without restoring those funding cuts. You know, hospitals are businesses too and have to make really tough decisions about, you know, what service lines they can continue to offer the community, what staff they can hire, and even keeping their doors open based on the predictability of their funding. So having that up in the air constantly is really challenging. The other aspect I'll mention, just again at the federal level, since that's been on our minds a lot this week, is, you know, I think that in the hospital community, we shared the same concerns as probably both my fellow panelists around affordability of coverage, and we think it's an issue that really needs to be addressed. But we have concerns that the current American Health Care Act does not adequately address those concerns about affordability, and in fact might make things worse for individuals who receive their coverage through Medicaid or in the individual market. So trying to take a closer look at how we can make sure to maintain access for folks while it's also affordable would also go a long way towards helping stabilize the uncertainty hospitals feel when patients come to receive care and where their coverage is coming from and how expensive it is. And I guess the second half of your question, how has the uncertainty affected our organization internally, is that caught me off guard, and I'm a hard question to answer. I think off the top of my head, it makes it challenging to keep up to date on what's going on when things are moving so quickly at both the state and the federal level, and then how policy changes at each level of government affect the other. So as the federal government makes changes to funding for programs like Medicaid or Medicare or health insurance in the individual market, how will those changes affect what our state legislature decides to do and possible repercussions to our members?
So this is Steve. I'll add that while a number of us on the phone or on this webinar might have this as a peripheral part of their job, and so we pay attention and we understand what is uncertainties and what is happening and, you know, what the current outlook is today. But most people are trying to lead their life and work their job, and, you know, the certainty about whether or not they'll have healthcare coverage is something that they, you know, is difficult for them to speculate about. So whether it's the uncertainty that's created in the failure of Congress to appropriate money and pay the cost-sharing reductions, which destabilizes the market, or whether it's the uncertainty about whether Congress is actually going to pass and dismantle, pass a bill and dismantle ACA and do away with all sorts of coverage. I mean, that's just very difficult to put in the context of how you need to live your life today. So I think that's really challenging in terms of both making sure that people can engage in those kind of policy decisions with their members of Congress, and yet help them to understand that those things aren't going to happen tomorrow, but they are real risks and threats to how they receive care.
And this is Angela. I mean, we are greatly impacted by what is going on at the federal level. I mean, here internally, in years past, federal advocacy has kind of been on the side of what we do at OEHP, primarily focused on the state level. However, the intricacies and how the impact of what is going on at the federal level has with how our plans operate today. I mean, the products and rates for 2018 are already being filed with the Department of Insurance, and so just that having to have developed those with the uncertainty of what is going on at the federal level has been very challenging, and just whatever happens at the federal level, you know, being able to have a smooth transition from what we currently have today to whatever comes next. I mean, the ACA didn't just turn on overnight. It happened over years and to be implemented, and thinking that changes could be made overnight will just send the market into a tailspin. I mean, it is something that we are all laser focused on, and just the impact that it'll have on our state budget, which, you know, we have less than 60 days to pass our state budget, and we have to pass it under what we know today with the ability to come back and make changes if needed, dependent upon what happens at the federal level. But the overlay of the federal level on top of what is going on at the state has just made day-to-day work that much more to ensure that we're on top of every issue that comes down our way.
All right, well, thank you very much. That's about all the time we have, but before the audience leaves, we have one final poll question we'd like to ask you. As you may or may not be aware, HPIO has been getting more involved in doing more webinars, and we'd really like to know how you rated our webinar. Your feedback is really helpful as we continue to improve and get better at these. So if you could take a quick second and let us know, we'd really appreciate it. And then a few other quick reminders before you go. HPIO is going to be hosting the next in our online seminar series on federal health reform, July 14th, featuring Bob Lashevsky. The information for that is on our website and the website listed below. Also, I wanted to remind you yet again that the slides used during today's presentation, as well as a recording of the webinar, will soon be available on our website, hpio.net. And one last quick reminder, while you're on our website, you might want to check out the 2017 Health Value Dashboard and supplemental material. The HPIO Health Value Dashboard is a tool that tracks Ohio's progress toward health value, a composite measure of Ohio's performance on population health outcomes and healthcare spending. The dashboard examines Ohio's performance relative to other states, tracks changes over time, and examines Ohio's greatest health disparities and equities. So while you're on our site, you might want to check that out if you have not already. And with that said, I want to thank our presenters again for their time and insight, and thank you again for attending, and have a good afternoon. Goodbye.